far away, but still I'm sure we can make for a good discussion. What we wanted to discuss is, as you see in the title, what we call the evolution in the axSpA management in the light of international guidelines. And I am working myself in a very big rheumatology center, the biggest in Germany. I'm having a special interest in axial spondyloarthritis. I was also involved in the international guideline as a member of the steering group that published them 2 years ago, a year and a half ago. And what I will do is to show, based also from what I know from your local situations, I will show you how the guidelines work, how we apply them, also the evolution in terms of adding now IL-17 inhibition in our guidelines, and which has been a major step forward. And we will, of course, also discuss the differences between possible treatments, including biologic and targeted synthetic DMARDs. Now, I would like to also remind you that what we have is the old guidelines from 2016. They were published in the beginning of 2017, and the newer guidelines that we published in December 2022. There is no big differences in terms of how they have been conducted. So we have one phase 1, we have the second phase 2, and the third phase 3, where we really step by step go through the medication that we have available in axial spondyloarthritis, and try to put the patient in the best condition as possible, as soon as possible. And you will see that the timelines have now been shortened in terms of when we take decisions for the treatments. Now, going into more details, I would like to remind you that what we do is that we start our treatment by having a clinical diagnosis. That's the same as in 2016. We apply and recommend physiotherapy. We recommend exercising and quitting smoking as one major step for treatment. And this is even before any treatment with non-steroidals or others has started. So in patients who are even asymptomatic, we say that this should be applied. Even in those who may come with pain, we apply physiotherapy. These things we will discuss. When it comes to quitting smoking, which is something that many people really believe is something which is more kind of a general health advice, this is not so much the case in axial spondyloarthritis. There is even more behind this data. Here you see data from the British registry, where they checked for the patients who ever have smoked as compared to those who never smoked. And you see that there have been differences. They have been statistically significant. Let's say BASTA, BASFI, BASMI, in terms of having lesser disease activity in the non-smokers as compared to smokers. And even if somebody was a smoker and has stopped smoking for at least 1 year and longer, as compared to those who have continued smoking, the stopping of the smoking has decreased disease activity even further. And this was also statistically significant, even after adjusting for several variables. So altogether, and this is the same, by the way, for the other parameters. So altogether, we believe that smoking and even quitting smoking in the smokers makes sense for disease activity decrease. Now, regarding physiotherapy, there is unfortunately a lot of heterogeneity. We don't have the same interventions in all the studies. We have different duration of the intervention from 1 week to more than a year. We have different outcomes that have been taken into account there. So this is not so easy to understand. However, what we have seen is that, and here you can look at the green boxes, what is that 3 different physiotherapy approaches are useful for these patients. One is physiotherapy or exercises in the water. So water exercises, swimming, seems to bring some benefit. The other one is aerobic training. This means jogging, cycling, and so on. That is something that also brings even improvement in disease activity, and in both in ASTA and BASTA, sorry. And the other thing is stretching. Stretching exercises, here it was compared with laser therapy. This did not make any difference, but stretching seems to really bring something more in terms of function and global pain improvement. So altogether, there are not many physiotherapy areas that we would recommend, but those that are here, water exercise, aerobic exercises, and stretching seem to play a big role, and they are recommended for these patients. They can do it in the group, they can do it with a physiotherapist, but of course they can also do it themselves. And this is something we recommend together on top on quitting smoking as well. Now, of course, the patients that we see, they come to us because of issues that when they are symptomatic. Therefore, we would indeed say, in that case, on top to the other two exercises and quitting smoking and so on, we would start with medication. The first step to start is still the non-steroidal anti-rheumatic drug treatment. We say that we would titrate up to the maximum tolerated dose. So we really treat with full dose. Full dose is as much as the patient can afford based on the indication for at least 4 weeks, for at least 2 weeks and maximum of 4 weeks. Now, within those 4 weeks, we are also allowed to change more than one NSAID if the first one did not work well. What kind of data do we have to support that? We have done a study that showed that if you take patients, non-radiographic and radiographic, it doesn't matter, who have all a BASTA of more than 4 in the baseline, and you give them the maximum possible dose of NSAIDs, you decrease the BASTA significantly already after 1 week. So disease activity is impacted positively by NSAIDs. And on the other hand, if you continue the NSAIDs for more than 1 week or 4 weeks, you do not add anything more. So this study was positive in terms of showing the good effect of NSAIDs in patients with axial spondyloarthritis. However, there are two main limitations. First of all, what you can achieve at the first week, 7 to 10 days. If the patient does not respond within 7 to 10 days, I would change the NSAID. It does make much sense. The other thing is that indeed we improve the disease activity significantly, but still we are at high levels of disease activity. So NSAIDs are good for some patients, but the majority will still increase the average disease activity index. And therefore, although they are efficacious, the NSAIDs, we believe that they are just for a very limited amount of patients recommended. Otherwise, they are not really the best way to go in the long term. And you, of course, also know the safety issues we may have with heart issues, with kidney and liver issues, and so on. The other thing is how many patients we really put into remission, and that's from the same study. We took here the BASTA below 3 as the level of low disease activity. We took the ASDAS below 1.3 as the level of inactive disease, and the ASDAS partial remission as the level of remission. And you see here after 4 weeks of maximum dose, about 15-16% of patients were in remission. This is far too low. So again, there is just a very limited amount of patients who will, unfortunately, be candidates for NSAIDs in the long term. Now, if that all doesn't work, we would like to go to phase number 2. If the patients do well with the NSAIDs, they can continue with decreased dose, then we continue. But otherwise, we would like to go to a phase number 2. This is what the majority of the patients will do. And that means here that in patients with mainly peripheral symptoms, we would also consider sulfasalazine or glucocorticoids injection locally. Is there an evidence for that? So for the injections, there is some evidence that they help. Here you see a study where they took an injection by CT intra-articularly or peri-articularly, as if you would not do it with CT, more or less blindly by ultrasound guidance. The intra-articular injection indeed improved the BASTA in that case, and the pain in that case. However, you see after a week the patients increase their pain levels again. The peri-articular injection didn't do anything. So if one wants to avoid any kind of treatment for any reason, injections may be helpful, but they need to be done under clear CT guidance. It's a whole bunch of things you have to do for that. And unfortunately, this is something for very short period of time. And of course, it's also associated with radiation exposure. So also for us, not really the best way to treat patients. And when it comes to sulfasalazine, yes, we know that, again, peripheral arthritis may be treated with that. After 3 months in the registry from Norway, they did not find, here you see the p-values, they did not find any improvement of all of those parameters, with the exception of the BASTA, and especially here question number 3, which has to do with peripheral pain. But this is it. It's only the peripheral pain that may increase, and for that you also need 3 months. So also not the best way to go here. Now, when we speak about everything else that makes sense, of course, we need to speak about biologic DMARDs and targeted synthetic DMARDs. How do we do that? Well, we check for our disease activity statuses, and here we always check for the change in the BASTA, in the ASTAs. We have omitted the BASTA. This was in the recommendations in 2016, 2017. Now we rely only on the ASTAs, and here we recommend a change of more than 1.1. If that occurs, then the patients are doing well. If that does not occur, then we obviously need to go on to the biologic treatment. I would like to remind you that the ASTAS has 5 questions, 3 questions from the BASTA, 1 patient global assessment, and the CRPs are included. And there's also the cutoffs for low disease activity, including inactive disease, or high disease activity and very high disease activity. And the cutoff is here, 2.1. This is the change of the ASTAS, and this is the status. Yeah. There is a reason to omit the BASTA from the recommendations, and one of the reasons you can see in this slide in this study. What we did here was to take patients from Germany who were on a biologic, here on the TNF blocker at that time, and it's an older study where we analyzed the data. And we started, or the colleagues in rheumatology department started the BASTA, the treatment with a BASTA of more than 4. Here it is the blue line, the group with patients of BASTA more than 4. Some of them nevertheless started the treatment with a BASTA below 4 for any reason that I do not know, but these were the data. And the range here was 2.8 to 4. And some other patients started with a lower BASTA even of below 2.8. What did we see? We saw that in the blue line, according to the recommendations, BASTA more than 4, BASTA decreased over 2 years. However, also in the lower cutoff, starting from 2.8 and on, also here the BASTA improved, very similarly to what the blue line did. So this very much means that, and this is also the meaning, experience we had from daily practice, even patients who may not reach a cutoff of 4 of a BASTA may be candidates for a biologic. However, the recommendations so far did not capture them, and that's why we always started higher. It makes sense to obviously replace the BASTA with the ASDAS, for example, which is much more disease specific, and to meet the BASTA totally from what we take as a recommendation. Nevertheless, what physicians do in daily practice is, of course, their thing. But I just want to mention that here we have these changes, and the reasons for these changes of which parameter to use for assessing disease activity are studies like this one. And of course, when we talk about biologics, then about other treatments, we need to talk about logics and targeted synthetic DMARDs. And the very big change that this recommendation has, there's 2 big changes. This is the one, is that we do not only have TNF blockers here anymore, but we have included IL-17 inhibitors on the same level of evidence as TNF inhibitors before. We also have the JAK inhibitors. I will say a word about that later. Here is the word of caution because of safety issues that we have put here on the on number 2 as a reference. But again, the big difference is that we do not only have TNF blockers anymore. Now, the recommendations also say that we would start the current practice is TNF blockers as known, but IL-17 inhibitors as we know them now. If there is active inflammatory bowel disease or active uveitis, we would use a monoclonal TNF blocker. Etanercept is a little bit problematic here because there is no data for it, and there is also additional information that it may induce IBD. And if there is psoriasis, we would certainly use IL-17 inhibitors over, or prefer IL-17 inhibitors over the TNF blockers. So that is more or less the situation for the JAK inhibitors. We did not recommend them as similarly yet, simply because there's not enough data, and again there are also safety issues that we will discuss later. That we said that we need more data to really make a comment on that. But there again, everything is on the same level in terms of starting immediately after an NSAID. What's the evidence for TNF blockers? Well, I mean, everybody knows that. I think there is not much to say here. I would just like to cite one study only that showed that a TNF blocker is efficacious as compared to placebo or to NSAIDs. Here is a 1-year placebo phase in that study. And we had very good results already after a couple of weeks, which continued over a year, whereas in contrast, the NSAID patients did not improve. So they work, we knew that. What do we know about IL-17 inhibitors? Here the data with secukinumab that we have as the only IL-17 inhibitor with such long-term data. We published the 5-year follow-up now means a couple of years already back. And here you see that indeed, independent of whether or not whether you take ASAS20 or ASAS40, in the entire group, or even in those who first line were treated, so it's not the switchers from a TNF blocker, but these are the first line treatments, these are the TNF naive patients, they showed very good results. And you see that there is no big difference, in fact. So it's independent on whether or not you have pre-treated the patient. The IL-17 inhibitors in that case, long-term, worked similarly well in pre-treated and TNF naive patients. What about JAK inhibitors? Here just the example of upadacitinib. The results that we have had so far show similarly good results in terms of treatment. Again, there are other issues that we may prefer the one drug over the other, but just in order to be fair with all data, I think it makes sense to have mentioned that we do not see very big differences in the treatment effects. It is the individual patient that needs more care, that we need to be careful on. Regarding MRI improvement in inflammatory activity, here you see the 3 studies with TNF blockers. That's a study with secukinumab. Here with infliximab after 6 months, with etanercept after 1 year, with adalimumab after 3 months. And sorry, here this was after 6 weeks. You see that the inflammatory activity disappeared. So altogether, we are able to show that indeed very fast, within 6 weeks, what is it here? Within 6 weeks, we are able to decrease inflammatory activity significantly, and patients get rid of their inflammation in their spine and the sacroiliac joints. We also have the very first study now that try to prove the efficacy of biologics in patients with axial manifestations, but those who are PSA diagnosed. This is what we call axial PSA. And the very first study was with secukinumab, the maximized trial, where we gave secukinumab to those patients with PSA and axial involvement as compared to placebo, and we showed in those PSA patients with inflammatory axial involvement significantly better results with secu as compared to placebo, and those with placebo, when switched to secu, they were actually similarly doing well. So in fact, this confirms the efficacy on the axial disease of IL-17 inhibition with secukinumab. That was an interesting study because it was the very first of its kind, and there is no other study so far in that regard. Now, if we talk about what we would do when the patients have been treated, of course, we would like them to be in the remission, sustained remission, and then continue with tapering. And that is something that we, of course, also have stated clearly in the recommendations. This is not the case. This was not the case in 2016. Here we say clearly, please taper, and the better the patients are, the faster they are in remission, the better then we can continue with tapering over time. Are there any data? Well, there are some data with biologics that have shown that if you stop the drug here in that gray line, patients flare again. The lower the graph goes, the more they flare. However, if you continue in the one similar dose, or if you continue with the reduced dose, there is no change in the treatment effect. So overall, this is a clear evidence, together with other studies, to say that indeed it makes sense to think of tapering when the patients are in remission. Here they were in remission they either stopped or they continued with half dose or full dose. Now, the question is what happens if the patients do not do well? Here we have the situation that, and that's the second big change, big difference as compared to the old recommendations, that in phase number 3, we said if there is lack of efficacy and the disease activity is still high, please switch to another biologic, either TNF blocker or IL-17 inhibitor. Now we say, before you do that, please reevaluate the diagnosis, check for presence of comorbidities that may influence disease activity in terms of it being high before you change the treatment. And if active axSpA is confirmed, this means there's no comorbidity or issues that influence disease activity, or there's any doubt on the diagnosis, please first reconsider. What does that mean? Well, reevaluation of the diagnosis may mean something like this. For example, in this first patient, where we have a sacral fracture after treatment with a biologic long time after, the patient had an accident, there was a sacral fracture here, there was low back pain, and obviously the symptoms came from that fracture and not from any loss of efficacy of the drug. Or it might be that indeed there is a misdiagnosis. Misdiagnosis means here like osteitis condensans, where there's a lot of sclerosis both on the iliac part, but the MRI shows, and the MRI shows also sclerosis, but there was no inflammatory activity. Or there might be something like that, where we had the metastatic carcinoma after long periods of time, this time without the treatment, but still when it comes to that, it might be that you have low back pain due to metastasis, or also in patients with DISH, who may also have some slight inflammatory activity, but there is new bone formation mainly in the thoracic spine that has nothing to do with spondyloarthritis. So all these things need to be taken into account. We also know, by the way, that the diagnosis may be put in, or may be questioned when especially the MRIs have been misread and misunderstood. And there's misdiagnosis. There is this Dutch study here that showed that not only in axial spondyloarthritis, but also, for example, in females after giving birth, or in frequent runners, or even in healthy volunteers, there might be up to about 20% of people with an MRI that is positive. And this is one study of ours where we found that indeed bone marrow edema, this is the same patient in three consecutive slices, bone marrow edema may indeed be look like positive, even in a healthy volunteer below 45 years of age. So we just need to be sure MRI has been read properly, the radiologist is aware of what they are doing, and we have the clinical symptoms that confirm the diagnosis. How do you look like that? Well, just very briefly, you have MRIs that look like this. It's a lot of inflammation. It's around the middle part of the joint where there is cartilage. That is spondyloarthritis, as compared to very little inflammatory activity, which is more in the ventral part. This is more a bone stress like edema. Has nothing to do with SPA. Just as just so you see how we would read these MRIs. There's also other reasons to fail treatment or not to respond to treatment, and especially this has to do with obesity. So these are the p-values for those interactions of those BMI categories. You see here in obese patients, the category, this is the patients in the obese patients, the treatments were much lower or lesser patients have replied or have responded to the treatment as compared to the normal or the overweight patients. So overall, obesity may also play a role, especially because then you're also moving lesser and so on. And there's also these studies, one from Italy, one from Switzerland, that show that there's differences between males and females, especially for the males, there is more chances to become a patient with a partial remission as compared to if you're female. And there's also here the p-values between males and females also for the other outcomes, as 20, as 40, ASDAS, and so on. So altogether, there's many different reasons to unfortunately fail, primarily the treatment, and these need to be taken into account. There's also this issue of secondary fibromyalgia. Here you see the p-values between those who had or those who did not have fibromyalgia on top of spondyloarthritis. If the patient does have secondary fibromyalgia, or central sensitization, as we call it, issues, then there might be also lesser effect of the treatment. Now, importantly, we also need to know when we lose our patients. For lose means when they relapse. And there is a study with etanercept that showed that there is a high amount of patients with, especially with TNF blockade, we know that you lose within the first year. This is the blue line. See, these are the relapses. This is the percent of patients with relapse. These are years 2 to 6. But the very first year is critical because there is exactly where we lose the most of the patients, again, as shown in that study, which also confirms my clinical experience. So altogether, we also need to be aware that we need drugs, we need treatments that are not only efficacious, but also safe. And there indeed, there might be different reasons for leaving the drug, for stopping the drug, either safety or inefficacy issues. But again, these numbers are pretty high, up to 40% only remain in the treatment. The others leave the treatment, which again may become problematic. This is of course also why we need more treatments than just the TNF blockers. Now, arriving at phase number 3, we say that if somebody has fulfilled everything that we believe there is a right diagnosis and there is still high disease activity, in that case we would suggest to switch to another biologic, either the TNF blocker or the IL-17 inhibitor, or if there is clear reason to the JAK inhibitor. But again, this is a bit left aside because we need more data for the JAK inhibitors here. And interestingly, we have conducted a small sub-analysis, I have to say, with not so many patients, but this is what we had. It was 80 and 146. Where this is now with ixekizumab, but it's about the concept, IL-17 inhibitor versus TNF blocker, where we said, okay, what if the patient does not reply, does not respond to the TNF blocker in the beginning? Does he or she respond to ixekizumab or to IL-17 inhibition later? And we found that 1 out of 4, which is not little, 1 out of 4 of the patients who do not respond to a TNF blocker before will respond to the IL-17 inhibitor after, which is something to consider. Of course, we do not know who is the patient to start with IL-17 inhibition, who is the patient to start with a TNF blockade in the beginning, but obviously this switch makes sense. And again, I come back to what we had before, then this is all for the phase number 3. If we go back to phase number 2, regarding remission, we also need to take into account that those in remission in good efficacy statuses, they will continue, and they need to continue with lower drug doses, but of course, with being efficacious. Now, this is relatively easy, I believe. It makes sense. It's trivial. We don't need to discuss it longer. But one important thing that we need to take into account here is what happens beyond disease activity. And that thing is the issue of radiographic progression and syndesmophyte formation. Now, let's take this from the beginning. We've shown in this study that if you treat with a biologic, independent of what that is, this is baseline. And you see here the inflammation. 3 months later, the inflammation will be gone. So we know that there is good efficacy here. What we did in that study, though, was that we added a specific tracer in a PET examination that is specific for osteoblasts. And here you see the osteoblastic activity in the beginning, here in the hybridization of the image, the PET MRI. But the positive message of that study was that when the inflammation is gone, then the osteoblastic activity is also gone. So we do have a true disease-modifying effect by treating with biologics. We don't see that by NSAIDs, by the way. Now, in order to prove if this is also well happening with the drugs that we see in what we measure, so the drugs that we use as with what we measure, this means with either TNF blockers or IL-17 inhibitors. We conducted a study that was called SURPASS, and the SURPASS study was having a primary aim to see if there is lesser radiographic progression with one or the other drug, secukinumab or adalimumab biosimilar. Now, the effect of the TNF blockers was well known, so we knew that indeed we have a positive effect overall, as I showed you before. And what we found was at the first sight that there was absolutely no difference. So the positive effect that we knew from the TNF blockers You see here the lines overlap. The progressors are the same. These are the progressors here. The positive effect that we knew from the TNF blockers was seen also for the patients with secukinumab, which is positive in a way that, again, we confirmed the good effect of TNF blockers, but we did not see a difference again. We dipped more into the data and found that there are some changes and differences, especially when we treat with IL-17 inhibitors compared to the TNF blocker, especially when we measure the progression. So here we take every patient and say who progresses and who not. Here we measure the average progression in the whole group. And we found lesser progression with secukinumab as compared to adalimumab. These are now data that are going to be published soon. This is only for 2 years, so I do assume that this line may have changed if we would follow up our patients over 4 years. We don't have the 4-year data, but it seems to be that there is something in here. There is a difference, which we need to understand a little bit better between the different treatment options. Now, I was asking myself, and we have some evidence on that, that's why I put it in here, how we can really work on this concept and how to explain that concept. And you see here that we know from data that were shown at ACR in 2015, here's the reference, they were then published in 2017 in full, I forgot to change the reference here, from rats. And these rats had the SPA model. They were infused for having the arthritis that we know, in peripheral spondyloarthritis as we know it from rats. And what they showed was not only arthritis, they also showed peri-osseal ossification. This is new bone formation. When the rats were treated with an IL-17 inhibitor, this ossification, this new bone formation did not happen. So there was indeed the hint already that we may be able to stop radiographic progression, which we did not entirely show in the human yet at least. However, we also have good data to show, to believe that there is some good efficacy here. These are data that we published long ago, and we try to understand the biomarkers that we do not measure in daily practice, but they might be important for what we do with our treatments with our patients. And the biomarkers, the most important biomarker for understanding radiographic progression is DKOPF1, DKK1. This DKK1, when it's low, you have no protection. You get new bone formation. When it's higher, you are protected. You get no new syndesmophytes. And what has been shown pretty nicely, this is one of the different studies that have shown that, is that if you treat with an IL-17 inhibitor, this DKOPF1 increases, so you get more protection. The same is for sclerostin, another biomarker, shows exactly the same. Here is at baseline within 1 month. Here is after 3 months. Here is after 6 months. The longer we treated the patients with the IL-17 inhibitors, the better the protection was against TNF blockade. So there is, against new bone formation, sorry. So there seems to be a good effect, but it takes time. This we need to understand, and that's why it's also important to not lose our patients within the first year, to really continue for a long time with the treatment, as we know it also with the IL-17 inhibitors and the biologics in general. And then they do not only improve and benefit clinically, but they also benefit radiographically. What about safety? Well, I will not give you all the data because it's a lot of data to report about safety. What I've brought here is 2 or 3 slides only, which are, I believe, important since we know that IL-17 inhibition especially, but also TNF blockers with their limitations are safe drugs. What we did here was to take the 5-year secukinumab safety data in patients with psoriasis, psoriatic arthritis, and ankylosing spondylitis. And we checked for all the possible drug-related adverse events, as we also know them from TNF blockers. And the main thing that you see is that we have almost everywhere either zeros or, let's say, extremely low numbers. Wherever I would go my cursor, you see in the beginning it might be something, but otherwise you lose it. So there is no there's no clear, let's say, signal for any kind of issues. Even the IBD part was very low, which is the reason why we do not say the patient should not be treated with 17 blockade if they are inactive. If they are active, you just don't have any effect with the IL-17 blockade, but otherwise this is not a contraindication. So altogether, very low rates of any adverse events with IL-17 inhibition across all indications. In the preparation of this talk, I was, of course, also looking for something that is more relevant to you than it is for us, which is tuberculosis. We do have some patients who come in and they have latent tuberculosis. However, I can tell you that there is almost no data here, and this is simply because we know that IL-17 inhibition does not affect tuberculosis at all. There is in vitro data that has shown that even the bacteria do not grow if you put IL-17 inhibitors, especially secukinumab. This was the first data there on them. It's different from the TNF blockers that, where you have the granuloma that may resolve. And the same also for JAK inhibitors, we have to say, because there you have a multi-cytokine approach. But for the IL-17 inhibition, this is not an issue. We have to do the tests, unfortunately, still in Germany also. But this is, at least to me, nonsense. It doesn't make any sense for that because you just don't need it. Okay, it is on the label, but in fact, there's no effect here. And the other thing that is important, I mentioned safety with JAK inhibitors before. Without wanting to speak bad about the one or the other drug, there is still nevertheless the issue that we need to discuss. And the most important study that has, I think, that is maybe even the most cited study in the last couple of years in rheumatology is the so-called oral surveillance study, where it was tested whether or not there is MACEs, myocardial infarctions, and also thrombosis, peripheral thrombosis in those patients who were treated with tofacitinib, as compared to now TNF blockers. That was the study. The study failed. It did not meet the primary endpoint. And not meeting the primary, you see here the confidence intervals, not meeting the primary endpoint means that tofacitinib in that case was having or showing higher rates of MACEs and pulmonary embolism and thrombosis. So altogether, there are warnings both from the FDA and the EMA here for when we treat with JAK inhibitors, both in rheumatoid arthritis, but also in spondyloarthritis and psoriatic arthritis. We can go into details if you wish, but this is a little bit the problem we have with the JAK inhibitors. Although they seem to be efficacious, the safety events that we have to take into account. Now, by that, I'm at the end of my presentation. I hope you enjoyed it, and I'm really very happy to take up questions. Thank you.